webinar, which is the fourth of our series of webinars prepared by the EURO-NMD ERN and by the Peripheral Nerve Diseases Working Group. We have two presentations today, and the topic is multifocal motor neuropathy and diagnosis and treatment, which will be discussed by Professor Thomas Harbo, and update on MMN biomarkers by Emilien. I will introduce them later. Before, I just need to show you a few slides. The first one refers to the first webinar. Can you confirm you see it?
I will.
Yes.
Okay, thank you. This is the first webinar was given by Philippe Timothy and Jean-Philippe Planson, so both clinician and patients, and it's thought for clinician and patients. And the last webinars will be on the 27th of March, again led by Philippe and Jean-Philippe, and we are asking for questions from you. So please have the QR code taken by your phone, and this is the way you can deliver questions to be discussed for the last webinar. So, and if you need it later, please ask me or Elizabeth through the ERN Coordination Center. The second point I want to touch is the patient journey program, which is something that is particularly important for the patients, but also for the clinicians. This is a program joined by patients and clinicians, and it's a project of the EURO-NMD. And the idea is to develop a path for some diseases, neuromuscular diseases, dealing with the medical, social, and psychological issues that the patient can come across during the path in the disease. And so a description of the diseases through the eye of the patients, but also with the knowledge and expertise of clinicians. So the perspective of the patient, but the knowledge and expertise of the clinicians. And specifically last year, a patient journey on multifocal motor neuropathy was developed, dealing with the step in main symptoms and impact, diagnosis, treatment, patient's needs, and follow-up supportive care to be developed. So with the eye of the patients and the knowledge of the clinicians, and very useful for patients, very nice project. And you will find them in the ERN website. And the next one will be on myasthenia gravis and myofibrillar myopathies are being developed, and ongoing on myositis, ALS, mitochondrial neuropathies. The first two are already available. The others are being developed, and you can find here the QR code for going directly to the website. So I wanted to give this information to you before starting the webinar. And the first speaker will be Professor Thomas Harbo, who is Associate Professor of the Institute of Clinical Medicine, Aarhus, in Denmark, and also Senior Consultant in the Department of Neurology in Aarhus, where he became a specialist, and then he had the period of had a neuromuscular fellowship at the Johns Hopkins Hospital in Baltimore, which is very, very important. And his clinical and academic career was mainly focused on inflammatory neuropathy, dysimmunopathy, GBS, CIDP, multifocal motor neuropathy, and where he gave very important contribution. And he's currently the secretary of the Inflammatory Neuropathy Consortium, Special Interest Group of the Peripheral Nerve Society, member of the Global Medical Advisory Board GBS CIDP Foundation International. Also now he's the chair of the PNS Guideline Committee, importantly as well. And Emilien, who will speak afterwards. Emilien Delmont is a neurologist, very well appreciated as well, like Thomas. He graduated in Nice. He had an MD and PhD. And then also importantly, he completed his postdoctoral studies in Glasgow in Scotland with Hugh Wilson, I suppose, that was very important in his development of the career and for his studies. And indeed, he's now working at the Referral Center for Neuromuscular Diseases and ALS in Marseille. And also he had made very important studies on autoimmune neuropathy, CIDP, MMN, anti-MAG neuropathy, nodopathy, and important studies on antibodies in this field. So thank you both for being here. We thank you very much for giving this webinar. And Thomas, you can start with diagnosis and treatment. You can share your slides. And before you start, while you're sharing slides, I remember that all attendants can make questions. You can write questions in the ANQ box or in the chat, or at the end of each presentation and the end of the webinar, you can make questions live if you want, if you prefer. We are collecting questions and we will discuss briefly after Thomas' presentation and at the end for both presentations. Thomas, we don't see your slides still. So it takes always a little bit. Okay, they are coming. I see myself, which is not as beautiful as your slide. We are seeing your slides now. Perfect. Go ahead, Thomas.
Good afternoon, everyone, and thank you for this nice introduction. It's truly an honor to have this opportunity to lecture on one of my favorite disorders and talk about the diagnosis and treatment of multifocal motor neuropathy. I have some disclosures and I have to disclaim before I make this announcement for February MMN Awareness Month from the GBS-CLDP Foundation. So please share that with your patients. So my lecture today will include an introduction to MMN, a patient case, diagnosis and differentials, and an overview of current and future treatment of MMN. So my part of the talk will be very clinical for you. So what is MMN and who can be affected? It is a treatable disorder with a relatively favorable prognosis. It's a pure motor neuropathy and motor nerve conduction block located at non-compressible sites is a key diagnostic feature. MMN is a ultra-rare disorder that affects less than 1 out of 100,000 people. It's more common in men than in women, and symptoms usually start between the ages of 35 to 45. So we don't actually know exactly what causes MMN, but I think that most of us agree that it is an autoimmune disease. And most recent studies indicate that it is more dysfunction of the nodes of Ranvier rather than in the myelin or axon of the nerves. And pathology studies shows contradictory results, with some showing demyelination and other studies shows primary axonal degenerations. But dysfunction of the nodal and paranodal area can prevent the propagation of the electrical impulses, leading to the classical MMN electrophysiological findings of conduction block. And then we see that in part of the patients, we can detect antiganglioside, GM1 IgM antibodies, and it is suggested that these antibodies induce complement-mediated injury at the nodus granuaire, which leads to this conduction block and weakness. When we do imaging, we can see that the motor nerves are enlarged, which is a typical finding in inflammation. And the fact that patient responds to immune treatment like cyclophosphamide and, more importantly, IVIG also supports that MMN is an autoimmune disorder. So you can hypothesize that in normal conditions, the nodes of Ranvier ensures the saltatory conduction, we know that, and gangliosides, GM1, maintain tight junctions at the paranodal regions and clustering of ion channels. But in MMN, the GM1 specific antibodies bind and activate complement, which leads to disruptions of the junctions and displacements and disruption of the ion channel clusters. Also, deposition of complement factors, including the membrane attack complex, might compromise membrane integrity and cause axonal damage. The symptoms of MMN is typically chronic, slowly progressive in a stepwise multifocal pattern. It's multifocal and asymmetrical, and it follows in the beginning the distribution of single nerves. It's a distal predominant disease, and it nearly always affects hands, but not exclusively. Muscle wasting is prominent, and cramps and fasciculations, and also worsening in cold conditions are typical findings. And then we don't see any sensory symptoms. So I will take you through this patient story that very well illustrates what MMN looks like and how it develops over time and how you can treat it. So this is now a 68-year-old female that we have been followed at our hospital even before I graduated from medical school. She had symptom onset in the 80s when she was 35 years old. It started with mild left ankle weakness, and a few years later, right hand weakness, and she had no sensory symptoms. And she was actually diagnosed with MMN as the first patient in Denmark. And if you look at the right side of the slide, you can see that the first paper describing MMN was from 1988, and in 1993, some of the first studies that showed effect of immunoglobulin was published. So this patient had GM1 antibodies. She had an EMG nerve conduction study with motor nerve conduction block, and she initiated IVIG treatment in 1992. And she responded very well to treatment with the standard induction dose of 2 grams per kilo, with increase in muscle strength and muscle function. And for many years, she was on maintenance treatment, IVIG 2 grams per kilo every 6 to 8 weeks. In 2006, she was included in one of our studies of subcutaneous immunoglobulin for MMN, and she responded very well to that as well. And since then, she has been on subcutaneous maintenance treatments with a dose that slightly increases over time. And her disease course is very typical for MMN, and despite treatment with IVIG, she has very slowly progression over time with affection of all 4 limbs today. Her current neurological examination, you can see a photograph of her hands on the right side, where you can see severe atrophy. It's also present in her distal legs and feet. And you can see her muscle scores listed up. She has normal strength proximals at shoulder, elbows, and hips. And when you go down to hands, fingers, ankles, she has very, very severe weakness with finger extension strength of 1 on the right side and 2 on the left side on the MIC scale of 0 to 5. And this is very typically for MMN. She is still full-time working as a professor at microbiology, and she actually have a lot of traveling through her work. So she's away abroad for long periods to Africa, places that is very rural, and she's happy that she can bring her subcutaneous treatment with her on these travels. She has severe disabilities, but she's doing very well with all these assistive devices that is also important for our patients. With a walking stick, she can actually walk 2 to 3 miles. She has a three-wheeled e-bike that she travels around in Copenhagen with, and she has a car with an automatic transmission and a handicap sign for longer trips. Dictus spans for both feet. She also have an AFO for her ankles, but it's uncomfortable for her, so she's not using that much. Then she have a loop scissor, you can see, special mouse pad, and bottom hooks, which makes her everyday life easier to handle. So this was a very typical patient with MMN in our clinic. When you should make the diagnosis of MMN, it's important to find the clinical findings at a neuromuscular expertise center, a history with weakness, with description of the progression and distribution, and the absence of sensory symptoms. And you see that also on the clinical examination with weakness and atrophy and fasciculations, loss of reflexes in the affected limbs. And then, of course, you should exclude other causes. The most important examination to confirm the diagnosis is the electrophysiology study, where you see the partial motor conduction block and conduction velocity slowing. And you should also see normal sensory conduction in the segments with the conduction blocks. There are some supportive findings for the diagnosis. It's elevated IgM GM1 antibodies. You often see slightly increase in CSF protein, and you can do imaging in the diagnostic criteria. It's MRI, but it is under revision now, and ultrasound will also be included. And you typically see this enlargement of the nerves in the brachial plexus. And then objective clinical improvement with IVIG treatment is also a supportive criteria. And it is important that you quantify these improvement with an MIC score, grip strength, or a disability score like the MMN rods. So this is the diagnostic criteria. They are from 2010, and there are three categories of diagnostic certainty with definite MMN, where you should have the clinical core criteria of slowly progressive, stepwise focal asymmetrical limb weakness in the motor nerve distribution of at least 2 nerves for more than a month, and then a normal sensory examination. There are some exclusion criteria: upper motor neuron signs, marked bulbar involvement, sensory loss, and symmetrical weakness during the initial weeks of disease. Then we have the important electrophysiological criteria with definite conduction block and normal sensory nerve conduction. And that makes the definite diagnosis of MMN. You can also have a probable MMN, still have the same clinical and exclusion criteria, and the electrophysiological criteria are a little bit less, with only 30% reduction of the area of the CMAP compared to the definite conduction block of 50%. You can also have a probable conduction block in one nerve and then two supportive criteria to make the diagnosis of probable MMN. You can even have possible MMN if you have the clinical criteria and objective response to IVIG, even though you don't confirm it with your nerve conduction study. Or you can only have it in one nerve, and then it's also able to meet the criteria for possible MMN. It's important to recognize the differentials to MMN, and we are aware it's a diagnosis that is missed very often, probably because it's ultra rare disorder and it's misdiagnosed as more common disorders. There are pure motor mimics like ALS, that's the most important, inclusion body myositis, spinal muscle atrophy, or distal muscle dystrophy. And it's also mistaken for multifocal CIDP, cervical spine disorders, entrapment neuropathies, brachial plexopathy, and axonal neuropathy, which are all very common disorders in the neuromuscular clinic. And again, the most important mimic to MMN is motor neuron disease, or ALS. They both have in common the weakness, the atrophy, and the fasciculations, but there are distinct features that can separate these two. So first of all, the distribution of the weakness, where in MMN it's always, or more or less always, distal, whereas in ALS it's proximal and distal. It's very rare that you see bulbar sign in MMN, which is frequent in ALS. And then the disease course, the progression is slow in MMN, faster in ALS. And in MMN, you often see the stepwise progression, whereas in ALS, it's just steadily going down. The progression pattern is also different because in MMN it can randomly hit single nerves. It can be in the right hand and the left foot, whereas in ALS it tends to spread more segmental, so it goes from the right arm to the right leg, or it goes from right arm to the left arm, but never crosses over. Then we see weight loss in ALS. It's a life-threatening disorder, whereas MMN is treatable. We don't see any hereditary MMN cases, which is occasionally seen in ALS. So these are important differences in the main MMN mimic in the clinic. So now we go to treatment of MMN. And immunoglobulin is actually the only proven effective medical treatment for these patients. And you can choose intravenous or subcutaneous administration. And what is the evidence based on? There's a recent Cochrane review on immunoglobulin for MMN, and the conclusion is not that overwhelming. So there are low certainty evidence from small randomized control trials that IVIG may improve muscle strength in people with MMN. And there's also low certainty evidence to indicate that it may improve disabilities. But the magnitude of improvement of disability have wide confidence intervals and needs further studies to secure its significance. Subcutaneous immunoglobulin might be an alternative, but still the evidence is very uncertain. So more research is needed to identify people in whom IVIG withdrawal is possible and to confirm efficacy of subcutaneous treatment as alternative to maintenance treatment in MMN. But nonetheless, it's the only available treatment, and the experience from the clinic is that it is actually pretty effective in MMN. And this is my treatment algorithm in MMN. So I start with an induction treatment course of IVIG, 2 grams per kilo given over 45 consecutive days. And then I assess the motor function with the grip strength or the MRC score or an MMN ROD score after 2 to 4 weeks and see if the patients improve. If they don't improve, then I would reconsider the diagnosis, because my experience is that with the right diagnosis, at least 90% of the patient will respond. If patients improve, I will follow them up, and if they start deteriorate again, I will start IVIG up again and then put them on maintenance treatment. In my clinic, it's mainly subcutaneous treatment, but it could also be intravenous. If they don't deteriorate, you could wait and see. Most of the patient will do at some time. It's important to adjust the treatment dosage and interval individually, because some patients need a small dose and other patients a larger dose. And if you give them too much, it has side effects, it's expensive, and we also have shortage of immunoglobulins worldwide. If you give too less, it will harm the patient, because you can see irreversible disabilities from the disorder. Some places don't have that much experience with the subcutaneous treatment, and that's why I will show this slides. First of all, there are some small randomized trial that supports that it's effective, and it is as effective as immunoglobulin intravenously. And reasons to prefer the subcutaneous treatment is reduced infusion-related adverse events. It's reduced or even eliminated treatment-related fluctuations in strength and function, what's the patient call the wear-off effects. Patients have increased quality of life and convenience because they can self-administrate at home. And then you also avoid the complications and inconvenience with the IV lines. But still, some of the patients prefer the IVIG, and they do that because of you have the local adverse events with sub-Q that you don't see with intravenously, and you have less frequent infusions. They know about IVIG. Many patients have been on that treatment for years, and they prefer to have their infusion conducted under professional care. Some don't like to put needles into themselves, and some places it's also difficult to get it reimbursed. On the pictures on the right, you can see how it is administered, and you can see on the lower right how it looks under the skin after 20 milliliters of subcutaneous treatment. So we only have immunoglobulins for the patients, but why do we need other treatments? So despite maintenance treatment, patients tend to slowly deteriorate and need higher doses over time. Some patients doesn't respond to treatment, and some have intolerable side effects and infusion-related side effects or thromboembolic events that prevents the treatment. And then patient needs lifelong maintenance treatment if we have this IgG shortage. Novel treatments in MMN is at this stage focused on complement as target. And you see the complement system on the right. There's a classical and lectin and alternative way to activate the complement system. And now we are focusing on the classical and antibody-mediated pathway. We have had some studies with eculizumab that blocks the last stage of complement, but it seems like more or better to go for the classical pathway and more upstream because you also have these molecules that opsonize and attract and activate immune cells that is probably important to be blocked. There are candidates in clinical development. We have C2 inhibitors where we have a completed phase 2 study and a phase 3 study that is recruiting at the moment. And we also have a C1s inhibition candidate that is in phase 2. And these are the results from the phase 2 study of the C2 inhibitor empasiprubart that was given in patient that was already on IVIG maintenance treatment, and then the treatment was stopped and patients were randomized to have empasiprubart or placebo, and you see that more patients on placebo tended to deteriorate and needed to start up their IVIG again. So it seems that we have some promising candidates at the moment or in the future for MMN. So with this, I will end my part of the presentation and thank you for your attention. You can ask questions now or at the end.
Thank you, Thomas. Very beautiful talk, very clinical, which is very, very useful and nice information. And we have a couple of questions soon. You can stop sharing. The first question is standard sensory nerve conduction study in distal limb segments sufficient to rule out sensory involvement? This is the first question for you, Thomas.
Yes, you are allowed to have minor findings on a sensory nerve conduction as long as it is not in the nerve segments with the conduction blocks. So if you don't see anything on on standard sensory nerve conduction studies, I would say you are safe to say that this is probably MMN.
Okay, thank you. The other question is also interesting. Newman Cheng is asking, what do you think is the underlying pathophysiology of MMN? Do you think it could be a combination, e.g. proximal conduction block from antibody-mediated axonopathy and perhaps secondary demyelination with disruption of the paranodal seal? And there is another question. Is a follow-up of the underlying pathophysiology. How do we explain why conduction block can be found in nerves or clinically unaffected muscles? And conversely, how imaging abnormalities can be found in nerves that do not have electrophysiological abnormalities? So dissociation, clinical electrophysiology, imaging, and pathophysiology. A complex question.
So that was, I think, several questions. And I agree. I think there's a mixed pathology in MMN. You can see that when you see the response to treatment, you have an immediate response on immunoglobulin. You see the patients improve already 5, 10, 15 days after treatment. And I think that is because of reversal of a conduction failure at the nodes of Ranvier. But then you have this underlying slowly progressive development that you see in patient despite treatment. And I think that have to be something that happens to the axons and some inflammation or disruption of the axons. But I think Emilien probably knows a lot more about that, and you can maybe repeat that question when he has finished his talks as well.
Yes, we can discuss it at the end of Emilien. Thank you very much, Thomas. Very, very inspiring, useful. And Emilien, you can start sharing your slides, and it will be a pleasure to listen to your talk on the update on biomarkers of MMN.
So thank you very much. It's a pleasure for me to be there with you. I was first very proud when you asked me to do this talk, and then I thought it would be very difficult to find some new biomarker and new things to say about MMN. So we're going to try. First, just to say that a biomarker, you know that they are used for the diagnosis. They are used.
Emilien, are you already sharing slides, because we don't see them?
You don't see them, sorry.
No, not yet. Just so before you start.
I thought I was doing so.
Okay, they are coming.
They are coming.
We see your screen now.
And do you see my slides?
Yes, okay, perfect.
So I'm really sorry about that. Is it okay?
Thank you. Okay, perfect. Go ahead.
So I was saying that the biomarker can be used for the diagnosis or to assess the severity of the neuropathy, or in the follow-up to know how the neuropathy is going. And the biomarker in bio, you have bio as biological, but you have also imaging and electrophysiology. So first, we are going to talk about biological biomarkers. And the first of all is cytokines. You have a few studies that analyze the cytokine of MMN patient in serum and CSF. Some say that maybe IL-1 is important in the neuropathy, but there is not too much studies, and these studies are too scarce and too small. And so it's very hard to say that a cytokine permit to make the diagnosis of the neuropathy or to be an effective and valuable biomarker in MMN. Then you have the neurofilament light chain. You know that we are using more and more this biomarker. And what you can see is it is a very good diagnostic biomarker. When you compare MMN and ALS, the neurofilament are very high in the ALS population, and they are low in MMN patients. So the sensitivity and the specificity is usually above 95%. So you have several papers, and I show you some examples from our cohort in Marseille, and you see that the MMN have low dosage of neurofilament, and that the growth curve are very good. But what we don't know is if we can use neurofilament as a biomarker to look for the treatment and to know how the patient are responding. And what we would like to have is one biomarker that, for example, when you stop the IVIG, to know if the patient is going to relapse. So we don't know if neurofilament can permit to do that. This, the third biological biomarker, which is famous in MMN, is antiganglioside antibodies. First, you have to know that there are several techniques to measure that antibodies. Usually people use ELISA and dot blot that you can see on the left of the screen. But when I was in Glasgow with Hugh Willison, we use a lot of array. And the good point with the array is that you can mix ganglioside and other glycolipids. And so you can see some antibodies which are enhanced by the mix of the ganglioside. They are called complex enhanced antibodies, and that we do in Glasgow, and what did Nobile Radio in Italy. So we mix GM1 and galactocerebroside, and you can see that the sensitivity, when you compare ALS and MMN, the sensitivity of this mixed of antibodies against GM1 alone was 40%, but when you mix galactocerebroside and GM1, the sensitivity was increased to 60%, with always a good specificity of 90%. But the specificity of these ganglioside antibodies is not 100%, because we all see patient with ALS, with typical ALS, but with positive anti-GM1 antibodies. And just to say that these antibodies are from IgM isotype. IgG is in Guillain-Barré. When you have these antibodies against GM1, they are going to activate the complement pathway. And you see on the left, in this study from VLAM, that people with high titer of antiganglioside have an increase in the complement deposition. And there is an activation of the complement pathway, and it is a classical pathway. You see on the right, it's a motoneuronal culture. And when you put serum from patients who have these antibodies against ganglioside, you have an activation of the complement, and you can see the expression of C4 and C3. If you put on the culture an antibodies which is against C2 of the pathway of the classical complement pathway, there is no more activation of C4 and C3. So it was what Thomas said previously. Maybe it will be a good treatment for a patient to use these specific antibodies against the complement pathway. But is the complement a biomarker by himself? It's not a good biomarker to make the diagnosis of the MMN, because if you compare MMN and control, there is no clear modification, and there is no increase of the complement protein when you measure each protein of the complement pathway. But it seems that it is associated with the severity of the disease, and it's always the studies from VLAM. You see on the right that there is more C3b deposition and more activation of the classical pathway when you have high titer of antiganglioside, anti-GM1 antibodies. But it's only one study, so there are results that we have to control. Here is the complement pathway. So you have the classical pathway, the lectin pathway, the alternative pathway. And in red, you can see protein, which role is to inhibit the complement pathway. So in one study, and this is a recent study, you can see that they analyze CD46, CD55, and CD59. And what they found is that there is sometimes a deletion in the promoter of CD55, and this deletion was more frequent in MMN patients, and it was associated with a more favorable disease course. Now we're going to talk about imaging. Imaging, so you know that ultrasound can be useful. This is another study when they show that here you have a normal distal CMAP and here a normal nerve on the US imaging, but just above there is a partial conduction block, and the authors show that there is an enlargement of the nerve. So you can have specific picture of the emulsion maybe when you use US, and this is a diagnostic biomarker if you compare ALS and MMN. Maybe there are differences between CIDP and MMN, but for me it's not as much as clear that in ALS people. You then know the plexus MRI. This is an example of enlargement of the plexus MRI of the cervical plexus. This MRI is abnormal. In this study, it was in 82% of all the patients with definite diagnosis, and it was 66% in the patient with possible MMN. You can see we studied 7 patients who didn't have conduction block at the classical electrodiagnostic test, but this patient had an abnormal MRI in 57% of the patients. So yeah, this imaging was able to show that there were plexus involvement and maybe proximal conduction block in this patient. What is interesting in MRIs is that you can do quantitative MRI. So you have to make the picture, then you have to make the section, to define the section of the muscle or the section of the nerve, but then you can have quantitative data. What is good, it's a very long examination to not to perform for the patient, but for the clinician, because there's a lot of things to do to have this quantitative data. But now, thanks to the IA, we have more precise data, and something that were taking something like 10 hours, now it can be performed in 20 minutes thanks to the IA. So we have quantitative data that are related to disease severity, and they seem to be sensitive to change during follow-up. It's thing that is demonstrated in CMT neuropathy, but not yet in inflammatory neuropathy. In MMN, there is only one study that is analyzing quantitative MRI. This study analyzed the leg and the arm. The leg, it was not optimal, so they gave more result on the arm, and you see that they have an analysis of the median, ulnar, and radial nerve, and they showed that there were a characteristic pattern with an enlargement of the CAC, with modification of the DTI and the T2 signal. But they didn't show, so they showed that there was a difference compared to control and to ALS, but they didn't show correlation with the severity of the disease. We don't have a longitudinal study to see the evolution and to know if these data are modifying by the treatment, for example. Now talk about electrophysiological biomarker. In Marseille, we are fond of motor evoked potential with triple stimulation technique. It's a technique that can show you when there is an involvement of the motor neuron, but also it can show if there are proximal block. And you see there an example. The same study as
sorry, Emilien, you are muted. You muted yourself voluntarily.
Sorry.
Okay.
It's okay now?
Yes.
I was saying that with the TST, you can show conduction block, and even in patients who don't have conduction block on the classical electrophysiological study, you can see abnormality that help us to make the diagnosis. Motor unit number index is a technique that permits to measure and to estimate the number of functional motor units. It is well shown that this technique and this number, the MUNIX, is related to the disease severity in inflammatory neuropathies. And this MUNIX number is decreased when you have a motor neuron destruction, when you have an axonal loss, or when there are conduction block. And when there are conduction block and no axonal loss, you have a normal distal CMAP, but a decreased MUNIX. This is important because when you do MUNIX before and after IVIG, the distal CMAP is not going to increase, but the MUNIX can increase. And you can see in this small study that we have 3 patients, it was 5 patients who had the IVIG and 2 examinations. You can see that the MUNIX is increasing up to 40%, yes, for the 3 patients, and that the CMAP was less increasing. So maybe it's an early biomarker to test the IVIG efficacy. So you see that there are diagnostic biomarker versus ALS, neurofilament, motor evoked potential, MRI, US. They seems to be good biomarker. We can have biomarker of severity, but it's just complement pathway, and we have to control this study. And for the follow-up, maybe the MUNIX, maybe the quantitative MRI and neurofilament, but we have to make more and more study because we don't have, I think, we don't have enough data, and we have a lot of work to do in MMN to have very good biomarker to cure a patient. I thank you for your attention. And sorry for all the technical issue.
No, perfect. Thank you very much for this very interesting presentation. Your task was not easy, but it was perfect. Excellent. We are open to questions. We are on time, perfect time. So we have time. I see coming this one. What is your opinion on axonal excitability testing in MMN? There seems to be some interest in it since it allows derivation of membrane and ion channel properties in vivo, and perhaps suggesting that different paranodal channels may be affected, e.g. juxtaparanodal fast potassium channels affect the nerve membrane recovery for refractoriness. Chang Newman.
Yes,
That's interesting. Yeah.
Yes, and I wanted to talk about that. But I didn't do it because in the studies, they always show that there are abnormality of the excitability. And so it's good paper to discuss the pathology of the MMN, but there are no clear comparison between MMN and other neuropathy. And so that's why I didn't talk about that, because I didn't thought it was a biomarker of diagnosis of progression. But I think it will be very interesting to test the excitability before and just after IVIG. And I don't know if you know François Wang in Liège. He have a lot of technique of excitability, and one is the IMAX, and he showed that the IMAX was changing just before and just after IVIG in CIDP, and I think in MMN.
Thomas, you have Atichit and Kisi in Harbo's performing excitability tests, so this would be interesting to test on your side.
Yeah, I'm pretty sure that Hachit Tankisi would be happy to do that.
Yeah, good suggestion, very interesting. We have Amedeo De Grado here with us, who was previously learning the technique in and with Atichit. So this is a very interesting topic. We have a couple of other questions. This one may be more for Thomas. Can proximal weakness and plexopathy-like presentation occur in MMN?
Yeah, it certainly can, but it's not the usual presentation of MMN. But you can have a proximal weakness as the first symptom. But you should be aware that that there are other differentials. Be very sure that you don't have any sensory symptoms or pain that makes it more likely to be nerve entrapment or plexopathy. But it is seen.
Okay, another question from Saka Odemir is, would you recommend studying the mixed sensory nerve, sorry, it's moving, in the segment with conduction block to differentiate MATSAM from MMN? MATSAM, the distal sensory motor demyelinating neuropathy from. Who wants to answer? Thomas, you mentioned that there is no sensory involvement where there is conduction block. So this.
I can start, but I'm not a electrophysiologist, so I would tend to ask them in the electrophysiological department. But there are some nerves where you can do both sensory and motor, but there's certainly also someone where it's difficult. But if you don't have any sensory symptom in that area, then I don't think it's that important.
Okay. Another question is how to differentiate HMPP, hereditary neuropathy with liability to pressure pulses, versus MMN, as both have nerve pattern weakness with conduction block. The conduction block is different than placed. So who wants to answer?
I can answer, please. The conduction block are not in the same place, because when you have thoracomacular neuropathy, the conduction block are at the elbow or at the wrist. They are not at the forearm, or they are not at the herpes point. And you have sensory involvement in HNPP. And in MMN, you don't have the sensory involvement, and the conduction block are not at the site when you can have compression.
Yeah, clear.
But sometimes it's hard to difference CIDP and HNPP. It's clear. It's true.
Yeah. Cheng is asking again, because maybe we haven't answered completely. May I ask again, what are your thoughts why conduction block can be found in nerves of clinically unaffected muscles? And conversely, how imaging abnormalities can be found in nerves that do not have electrophysiological abnormalities?
I can try.
Okay.
In the paper with the US, I show you just a little part of the paper, because there were one pattern which is a clear pattern with conduction block, electrophysiological conduction block, and abnormal US. Then they had abnormal US and no conduction block, and then conduction block and normal US. So they had the three pattern, and we don't have always the imaging and the electrophysiological examination who show the same thing. It's just because it's not the same thing. When you do imaging, you just see a picture, and when you have abnormal MRI or abnormal US, you just see edema. If you have a little edema, maybe you don't have an effect on the conduction, and sometimes you can have a trouble with the conduction with no major edema, and so you can have your conduction block but no abnormal imaging. But it's true that we would like always to see the same thing, but sometimes it's not a very large involvement, and it can be only an involvement on some fiber of the nerve, and sometimes you have a big destruction of the nerve and a big edema, and sometimes it's just something functional. And in this case, I think that the imaging is normal and the IVIG are very effective and rapidly effective.
Yeah, from the point of view of clinical involvement versus conduction block, also in HMPP, you can have clear-cut conduction blocks, but with normal function. And so it's not always corresponding. Another question is MMN with conduction block an axonal disease in view of cold paresis on one side and wasting atrophy on the other?
I think you can answer that, Emilien, better than I can.
It's my MD project. You know, when I was internship, Jean Pouget told me, you know, we have multifocal motor neuropathy with conduction block, and we had some patients who don't have conduction block. And the question was, are they motor neuropathy in both cases? Or the other hypothesis was that we have motor neuropathy and lower motor neuron disease and different disease. So what we do is that we compare the motor neuropathy and with conduction block and without conduction block. And the hypothesis was that if it was different disease, we will have different characteristic, different response to treatment. And when I compared these two populations, it was really the same. It was always an involvement of the nerve. It was always responding to IVIG in the same pattern. That's why at this moment we say that it was multifocal neuropathy without conduction block. And then we have the MRI, then we have the triple stimulation. And I think that this explanation shows that it's the reality. It's just that sometimes you can't see the conduction block, either because they are in part that you can't explore with a classical electrodiagnosis examination, or because you have too much axonal loss. And when there is too much axonal loss, you can't see the conduction block, but you can still see abnormality in imaging. So for me, there was a paper, I think it was from cats, which it was axonal motor neuropathy when I do my MD. But now I think it's MMN with or without conduction block that you can show or not.
Yes, so you are answering partly to the next question, which is when we see patients during the period of progression with symmetric muscle weakness, could conduction block be undetectable?
Well, I'm not sure I understand the question, but I think the problem with symmetrical muscle weakness is that if you see that in the beginning and with progression, then it's more likely to be CIDP or Guillain-Barré syndrome. And you can have nerve conduction abnormalities that is different.
Yeah, symmetry, so it's always suspicious. Now, probably this is during the course of the disease becoming symmetrical, but Emilien answered that conduction blocks sometimes are proximal, so you can detect them. Another question is, could a patient presenting with dysphagia and dysarthria, Thomas already answered to this, be affected by a very focal MMN with conduction block of the cranial nerves? How to improve electrodiagnostic diagnosis? How long should be treated with IVIG?
Yeah, that would be very unusual to see that presentation, but there are case reports that
the first case report from the Switzerland.
Is that true? But I think the disease course will show the answer, because the mimic is ALS, and that will progress and involve more and more muscles, and you have a lot of other symptoms and first motor neuron signs. And you could try IVIG, because if patients respond to that, then it's a supportive criteria. But you should be careful not to judge efficacy just by asking the patient if they subjectively find that it's a little bit better. But yeah, the mimic is probably ALS, and time will show. Other mimics could be inclusion body myositis, and you will also have a deterioration, and you will look at myopathy on the EMG. You could take a muscle biopsy, look at the CK level and the blood level.
And a question on my side to you both. Do you usually test one course of IVIG or two courses before saying this is not responder or shift diagnosis? Because we usually do a couple of cycles before.
Yeah, I think that's true. It's recommended in the CIDP guidelines that you should try at least two courses of full dose or 3 doses with half dose of immunoglobulins, and there are no recommendations in MMN. But if you have a patient with very long disease course with axonal loss, you probably need to give it a little bit more time. But in most cases, you actually see a treatment response right away.
Okay.
We do too.
You do too. Yeah. Okay. Last very quick question. The last one. Cold paresis are related to conduction block in the paranodal regions, nodal region, in your view, because of temperature. Is this the answer?
Yeah.
Yes.
It was Jean Léger was always saying that it was for him a very good clinical evidence of MMN when the patient said that the cold was worsening them.
Yeah, that's interesting. So it was fantastic webinar. Thank you very much. Very interactive, very useful clinically and also scientifically. Thank you so much. We need to close because we are a little bit late. Thank you very much.
Thank you very much.
Thank you. Bye-bye.
Bye-bye.
The webinar is available on the website, YouTube channel.
Goodbye.
Bye-bye. Thank you so
Thank
much.
you very much. Bye bye.
Bye-bye.
Bye.